let's get started. It's 4 o'clock European time in Stockholm and Copenhagen, where Graeme is, and I am in Copenhagen. Winter time is coming on Sunday, so it's kind of like the last day in the autumn where probably the sun is shining and so on. So anyway, today's topic is a webinar on infections. And I have, I don't know if infections has a special place in my focus for sure. I've had several weird infections throughout my life. I had tuberculosis as a kid, and I found out that I had Lyme's disease and lots of co-infections with both EBV and also Bartonella. And I was actually on antibiotics for 13 months. Thank God for the Cowden protocol that actually helped me to be able to stop taking antibiotics. Because every time I tried to stop, which I did several times, all the symptoms just came back. But with Cowden, the Cowden protocol, I was able to get out of it. And I think I stayed on Cowden for another 9 months, actually. So it was a hard one. But in that period, I also worked very closely with a medical doctor who was treating infections in Copenhagen. So it's a big, interesting area. And there's of course other infections and Lyme's and co-infections going on. So, but I will kind of let Graeme talk a lot more about that. And remember, we are recording and there will be Q&A at the end. So put them in your notes in the chat. I will try and answer if I can during the chat or when Graeme presents. And otherwise, I will save the questions for the end. And Graeme and I always end up having not a discussion, but like a chat where we, like a ping pong, perhaps more. So I just want to pay attention to some emails that have gone out to you, and that's the Mastering Gastrointestinal Health Program. At least it should have gone out, but I'm just going to show you where you can look more into it. If you haven't had it on your mail yet, then you will for sure get it. And now I have to find my, and go share, and let's see what happens here. I'm in Nordic VMS, where you all know, or DNA Live VMS, depending on which website you use. But under education, that's where I am right now. Up here, you can click on new training and courses. And you enter this shop kind of, and you can find Nordic courses. And then you can see you can get the Mastering Gastrointestinal Health where you just buy part 1 or part 2 or part 3, or you can get them all in one and save some money there. The first one is, we have the date, which is the 11th of November, 2021. So there's plenty of time to, get ready for that, about 2 weeks. So, but I can highly recommend it. Graeme really goes into details on both stool testing and SIBO testing and intestinal permeability, etc. So I can highly recommend it. And Graeme has done the course before, and it comes with great feedback from the participants. Am I right?
I think so.
I know I am. So yeah. Anyway, something has happened since we met last time, Graeme.
Are you talking?
Yeah, little wedding.
I got married. Yes, absolutely.
Congratulations.
So, thank you.
Yeah. So, and even though he's been very busy doing that and all the after waves and tidying up after having to take time off for a wedding, he's here with us. So thank you. And I will pass on the microphone to you, and keep writing in the chat so we can have some conversations at the end. but do you want to just share your screen?
Yeah, I'll do that now.
I'll let you know that I...
All right, so yeah, let's get started. All things, well, infection testing. I guess the first thing with infection testing, like of course most topics that we go into, it's pretty complex. There's a lot of different nuances. There's a lot of different opinions. And today, of course, we're going to talk about some of those opinions, but we can't obviously cover all aspects of all infection testing. We've covered some in the gastrointestinal tract, and we've covered some in mold. And today I'm going to focus on some other areas of infection, mostly blood and airborne. So first of all, I think it's just important to explain that infections can cause a wide variety or a wide range of symptoms and conditions. So that can be pain and chronic fatigue. It can actually trigger autoimmune disease, and infections are also linked to neurological conditions as well as many other factors or syndromes. So it's always something that should be in the back of your mind when working with patients. Might not be the first thing you test. Of course, you need to do some good homework and get your detective hat on and look at when symptoms have started, and then really work back over the patient timeline and see if it's something that should be moved kind of higher up the order of importance. Now, of course, infections, well, they can come from many sources and they can affect different parts of the body. But as I said, I'm going to focus on airborne and tick-borne infections today. So, of course, that can, well, especially airborne, we think about viruses or mold, and tick-borne, of course, like parasites and bacteria. So, yeah, these infectious microorganisms mainly fall into these four different areas, and they can harm us in different ways. So it can cause inflammation, autoimmunity, it can cause tissue destruction by that pathogen or by the immune system. It can cause nutrient depletion because the immune response itself to an infection, that exacerbates a poor nutritional state and causes an increased demand for micronutrients. So you really have to think about that. And then we can get homeostasis changes because, of course, infection is a stressor. That can increase stress hormones, which elevates blood sugar. We get changes in blood flow, increased heart rates, metabolism, vascular changes, etc. That can affect sleep, which then again increases stress hormones, affects blood sugar balance, etc. So there can be, of course, a wide variety of different biochemical and physiological nervous system outcomes because of infection. And then, of course, we have fever, and then also some infections, of course, are linked to cancer as well. So it's quite a serious topic subject. So when to consider infection testing. So these are probably the main signs that I would look for. So of course, the obvious one would be that symptoms start in conjunction with an infectious episode. So it's, of course, it's if there's a tick bite, for example, and then the patient develops symptoms, that's very easy to possibly explain and to dive into that kind of testing. If there is a sudden onset of symptoms, if there is some level of fatigue involved, of course, fatigue is involved in pretty much all like diseases and syndromes and issues. So that is a tough one, but you're really looking at fatigue with some of these other symptoms as well. Of course, a trip to an exotic country, tick bite, we've already talked about a number of times. So symptoms worsen by exercise. So especially seen like the herpes family of viruses with viral reactivation there, particularly linked with that. And then sore throat, reoccurring fever, sinus issues, blisters on the skin or in the mucous membranes. So when I see patients who have ulcers in the mouth, for example, that come and go, you know, they get a bit worse by exercise or can't exercise or push themselves properly, with this feeling of fever that may, or of course may not actually, you know, register with a temperature test. So these are all reasons why you might want to test for infection. Now, this is a really cool diagram by Cogents, and if you haven't done or seen any of their courses, they have some really cool stuff on especially the immune system and autoimmunity. So I just wanted to share this diagram with you. Can you see my arrow here, Anne-Catherine? Yeah, okay, cool. So I just wanted to talk a little bit about this diagram, because really you've got the core dysfunctions of chronic illness in red here. And then we've got the key immune system changes in blue and the key immune consequences of those changes in purple. And then we've got these additional factors driving immune system dysfunction. So of course, with chronic disease, which of course all of us on this call will see patients that have chronic disease, often a hallmark of that, or at the center, is inflammation. So when we suspect infection, which is here, and that could be different kinds of infection, it could be digestive infection, it could be some kind of Borrelia infection or herpes family virus, for example. What this is going to do, it's a main driver of inflammation. We want to slow this down. So of course, we want to try and find the infection. We want to treat that effectively. But in that process, of course, all these other things are involved. So it's not always just going in and finding an infection that may resolve the situation. You, of course, need to look at all these different aspects. Now, just very quickly to just touch on these different theories here, but Th1 is our, if you like, our part of our innate immune system. And then we have Th2, which is more our acquired or learned immune system. So when we have things like high stress level, it's going to co-activate inflammation. And also it's going to drive down Th1 status. And that reduced innate immunity will then also make us more vulnerable to infection. And it can also allow dysbiosis to occur, which of course then co-activates inflammation as well. Then we have things like brain inflammation, okay, difficult to measure with your average toolbox, but we have a lot of different tools that can potentially help to modulate that. And then of course we have all our environmental factors that most of us will be working with, everything from balancing blood sugar to hormones, looking at food and environmental impacts, detox defects, vascular O2 defects, and other additional factors as well that can drive dysfunction. So in order to really, if you like, normalize a situation where infection is involved, of course, in some cases, just going straight to the infection, if it's caught early, it's treated properly, that can help to resolve these other factors. But then sometimes, of course, in more complicated cases, you literally might have to work through a lot of these things. You've got to work on stress chemistry, you've got to try and lower inflammation, you've got to try and help to lower brain inflammation, deal with blood sugar imbalance, hormone balance, look at things like, of course, what we all probably will do naturally, food intakes and food patterns and fasting patterns, etc., etc. So it's of course not necessarily a simple process, and all of these parts of this diagram will drive other parts. So you potentially have to work on as many of these as you can at once, or certainly start in one area and start to progress through as best you can. I mean, the other good thing is that, of course, if we're addressing, for example, a patient has a Western diet and we're changing that, then that can have a positive effect on multiple factors here: inflammation, dysbiosis, stress chemistry, blood sugar balance, hormones. So of course, we have really cool tools in our toolbox that can address multiple of these different aspects that come out of balance. So with infection diagnostics, basically we have serology, so indirect indications of infection. These are things like the classic immunoglobulin testing. And then we also have direct indications of infection, like PCR, culture, and microscopy. And also with serology, we have Elisbot testing. So I'd say that it depends on the infection, but a lot of the time we're seeing patients at Nordic Clinic in Stockholm that might have had an infection for a long period. And Elisbot is one of my certainly preferred, if you like, measurement of infection that we use ahead of immunoglobulins. But you really need to understand that no method is perfect. There's drawbacks to each one. So it can be very difficult, especially to find and confirm certain infections. So all of these have got drawbacks. So I'm not going to cover culture and microscopy today, just because we don't have time for everything. And basically, so I'm going to start with immunoglobulin. So this is more the classic kind of, go to the kind of the GP, and they can run immunoglobulin or antibody testing for things like Borrelia. But it's indirect evidence, and it's based on antibody production from the B cells of the immune system. There are different antibody subtypes: IgM, IgA, and IgG. And for some infections, all three antibodies can be produced by the immune system and tested. Generally, or absolutely, an old infection is usually thought to be, of course, this IgG response. So you might find, for example, if you did an antibody test for Borrelia, you might find IgM is negative, IgG is positive. That tells you that there's definitely been an infection at some point, but it also may indicate there is possibly an ongoing infection as well. There's just not IgM antibodies being produced. So here I've just created some tables that you can read in a bit more detail about antibody testing, the pros and cons. So, for example, antibodies, the most common infectious agents of respiratory illness, tick-borne infections, tropical infections, intestinal infections. So antibodies are often used in that way. When the pros of it is when a particular microorganism is present in low numbers in blood, testing for antibodies is a way to get around that. But the cons are that it's indirect evidence of infection and may have a low sensitivity for some infections, especially Borrelia, for example. So infection can only be confirmed, not excluded. And it also depends on sufficient immunoglobulin production by the patient's B cells. So you need to take that into consideration as well. Now, one of the most, if you like, common antibody tests that I will run would be this TickPlex Plus. So if there's been a tick bite, and we want to screen for multiple infections at the same time, then the tickplex is a really nice option if you want to cover multiple infections at the same time and rule things out. Sometimes, of course, if patients are confirmed positive for Borrelia on normal antibody testing, for example, they may get treated for that, but they often do not get treated for co-infections by their GP. So this is also a test where that can be helpful to rule co-infections, as Anne-Catherine was talking about at the start in her case as well. So a bit of further note on this kind of testing. Chronic infections by stealth bacteria can result in very low production of these immunoglobulins because of the status of immunodeficiency in these patients, and sometimes there's no development of antibodies at all. Borrelia, for example, that uses antigen variation to escape immune defense, so it's pretty clever about hiding away. Chronic infection can then lead to lowered immunity, impairing antibody production. So this is why if you suspect a chronic infection, antibodies might not be the best test to run. You might want to consider an Elisbot, for example. There's narrow testing or time testing range, so you have to run this test at the right time. So for some infections, production of antibodies doesn't start until a few weeks after infection, and it can vanish completely after a few months. Sometimes the sensitivity of the test is low, and if you suspect that your client is immunocompromised, then also consider another type of test. So if we move over now to Elisbot, so there can be lots of different pathogens detected with Elisbot that are included here in the table. So it's a really good complement in cases where antibody testing has low sensitivity, and it can be especially used to monitor success after treatment. It usually should become negative about 4 to 8 weeks after the completion of efficient or effective therapy, because that's how long this type of cytotoxic T cell lives before it's replaced by new cells. The problem with Elisbot is it's not accepted by all medical practitioners or, of course, different countries and their healthcare systems. So some countries may run Elisbot testing and some will not and not recognize it. So it can be hard if antibodies are negative, but you've got a positive Elisbot. It can be difficult to motivate the patient's doctor, if you're not a doctor, to actually treat with antibiotics, for example. If you want to read a bit more about Elisbot method, it's here. I'm not going to go through that today. Then here are some examples of an Elisbot test result. We have Cytomegalovirus here. We have the lytic and latent form. And basically anything over or a 3 or higher is positive. And it doesn't necessarily mean that the higher the number, the worse the infection. So first thing, just really if it's 3 or above, you should definitely consider treating for that infection. So here we have Cytomegalovirus, Epstein-Barr virus, and herpes simplex virus. So in this patient case, we have basically a confirmed positive via Elisbot for Cytomegalovirus, Epstein-Barr and herpes simplex are negative. So when it's a 2, it's considered a weak positive. And usually for us to treat in Stockholm, we want definitely a 3 or higher. So in this case, we can target the Cytomegalovirus with a specific protocol, although a lot of the herpes family will be helped or will be better resolved by similar strategies, which I'm going to come to a bit later. So then we have PCR. So of course, if you're using PCR testing, it's like fishing with a rod and a specific bait. So it's looking for and amplifying specific DNA or RNA sequences, and any pathogen can be found as long as basically the lab has the primers that bind to that specific DNA or RNA, but the pathogen needs to be found in the sample in sufficient amounts. So good thing is this is direct evidence, but a con is there's low sensitivity for many microorganisms. So it's not optimal to use for microorganisms that are found in low numbers in fluid or tissue that is tested. So that's usually blood or basically spinal fluid. If you want to read a bit more about how PCR works, there's a slide here. And then just created an overview of the different infections and what methods we have within the Nordic system. So you can see, for example, Babesia, there's multiple different ways to test for it. And like we've already been through, there's pros and cons to each method. Of course, in an ideal world, you could run all three, but a lot of our patients don't have the kind of money to run all three tests. So you really need to decide based on how, the pros and cons of each test. When was this infection potentially started or obtained, and then try and pick the best method for what gives you those answers. So here you can see all the different options. So we've got all the different herpes family here, then we've even got SARS-CoV-2 as well in stool and blood. So a number of different options. Remember, pros and cons for each. It's difficult, it's confusing, even for the experts who work with this. No one method is perfect. So if we look at a client case, so this was a woman with ME or CFS, so diagnosed with chronic fatigue syndrome. She developed a bad and chronic cough, severe fatigue and dyspnea 8 years ago. And despite her severe cough and infectious symptoms, there was no infection testing ran by her GP or the hospital, and it was claimed that this was asthma. COPD was also excluded. And this patient, she was very unwell for a long time until she was finally treated with actually high doses of cortisone for asthma. Now that reversed her symptoms and she felt very well. However, every time the cortisone treatment was stopped, she crashed. She would recover partially and then crash again in 2016. So this had been going on for a very long time, and it was a bit of a horrible situation. So we tested for a few common infections, including Mycoplasma, which can cause fatigue and a cough. And this one came back positive via Elisbot here. And very simply, the doctor agreed to treat given the symptoms and the Elisbot results, and was treated with doxycycline, followed by a prolonged complementary protocol. So in this case, we used something called MIC-P, which is a research nutritionals product, along with multi-messenger and messenger number 1 to help if you like, modulate and support immune function. We used biofilm disruptor interphase plus because this infection can use biofilms. And then we used glutathione and turmeric for inflammation. And lo and behold, she recovered very quickly after treatment and was back at work. So it was really a fantastic result for this patient who'd been severely ill for at least 8 years. So when these cases and results come like this, it's extremely rewarding. And of course, the patients are always so surprised and happy and often just annoyed that they were never tested for infection in the first place. So when we're treating for infection, I think you've got to, we look at 4 different areas, and you've got to try and combine all these areas. So you've got what we would call the fundamentals. You've got diet, sleep, stress management, movement, nature, sunshine, hobbies, fun. And it's important to get as many of those as possible in the kind of optimal, if you like, setup. Some of those are harder than others. Of course, some with infection, it's going to be really difficult to move or exercise, etc. But those things, of course, we all know on this call that it's important to support them as best we can. Then we're going to use strategies, usually supplements, to help support the immune system and to lower inflammation. And then we've got, of course, pathogen-specific protocols. Now, here I've just included this slide to identify really the more dangerous infections that shouldn't be, well, don't want to mess around with any infection really, but especially these in red here. If a positive result comes back for those, if you're not a medical doctor, it's good to refer them back to a medical doctor for proper treatment, because if these things go untreated, it can become literally a lifelong struggle, and non-prescription options may not be as effective as pharmaceuticals in certain circumstances. So of course, there's some stories the other way where some patients have not been helped by antibiotics, for example, and have gone to herbal protocols and been helped. But still, remember, if you're not a doctor, you've got to do your due diligence and make sure that, okay, at least the most important medical overview and treatment is done first. So treatment strategy wise, again, you can offer complementary antimicrobial protocols if the patient's doctor does not want to treat the infection. If it concerns an infection that is not classically treated at all in standard medicine, for example, reactivation of Epstein-Barr virus, then it's really good to use an antimicrobial, herbal or complementary protocol. And you can use them together with pharmaceutical antibiotics, or as a prolongation of the antibiotic treatment. So, and Catherine was a good example at the start of the call today, where she had the antibiotic treatment and it was helpful, but couldn't stay on that long term, so switched to the Cowden protocol in her case. So some commonly used antimicrobial herbs and blends. So we have broad spectrum biocidin, we have grapefruit seed extract, we have artemisinin, we have MICP for mycoplasma. So always just check for drug interactions before you use them. So for example, we use things like the Natural Medicines database to make sure that if the patient is on any other medication, we're not going to stop that from working or affect how it's metabolized. And then there's a lot of complementary, if you like, supporting supplements. So there is one called Transfer Factor Line Plus, which is another Research Nutritionals product. You have biofilm disrupting enzymes interphase, which is Claire Labs, for example, for mycoplasma. We have IgG supplementation, so products like ImmunoGG or colostrum. Now, vitamin D, that strengthens the Th1 mediated antiviral defense. So we often will use that in cases of suspected infection. There's inosine, which also is thought to stimulate Th1. Then we've got vitamin A and zinc, which is essential for immune system function. Of high dose vitamin C, so that can have antiviral effects. So use that for Epstein-Barr reactivation, for example, and then also things like beta glucans. So there's a lot of different options out there. Cowden protocol, it's not one that I have any clinical experience with. So maybe I'm hoping that Anne-Catherine can answer more questions on that one, if we have any. But it is there, and yeah, practitioners use it and report success. So that is an option in the system if you need that help. And then, of course, herpes family of viruses, we do see quite a lot of herpes family reactivation. And we see in like long COVID cases that some of those cases have herpes family reactivation, and we use a lot of different products like this, from lysine to resveratrol, vitamin A, licorice, boswellia, etc. So there's actually some good research behind some of these with effectiveness against herpes family reactivation. The like complex infection, Coxsackie virus, we have a product called BLT, again, research Nutritionals. Then there's these other supplements as well, stevia, Coumadin, cemento, serrapeptase, Berberpinella. So these can be effective at treating that virus as well. But yeah, I guess some of the challenges with the herbal protocols is that they're often involve multiple things, and they can get quite expensive for some patients. So again, it's something you need to take into account about how best to help. And then, as said earlier, for the Mycoplasma case, these were the supplements that we used after the pharmaceutical treatment, using glutathione and turmeric to help to lower inflammation. So yeah, that comes to the end of the, if you like, the slides for today, but I hope it gives some brief overview about the pros and cons of the different tests. As I said, it is a very complex subject. It's a very interesting subject. And if your patient reports symptoms like we went through at the start, then certainly infection testing is something you should consider and try and rule out. And remember to try and, yeah, there's no perfect test, but you should consider using either antibodies, Elisbot, or PCR, or a combination of all three, because it is complex. So you might need to run more than one different method to get an answer. Okay.
Super, thank you. So a question came up because we need to add an extra line maybe on your slides, because in GI map there are some viral infections that comes up, and the question goes a little bit on how do we, so one thing is in the blood, but how do we then translate the information from a stool test on the positive virus infections in the stool test?
Yeah. I mean, I think I don't know how many GI maps I've looked at over the years, but I would say I think I've only ever seen maybe one or two positive like Epstein-Barr. I think I've seen one positive Epstein-Barr in the gut and one positive cytomegalovirus in the gut, or over the last, yeah, however many years that's been available. So it's not very common. And of course, the adenovirus or norovirus on the pathogen page, if that's active, the patient will have very severe symptoms, and then depending on how long that goes on, they might need medical treatment. But things like, yeah, digestively, like monolaurin can be helpful. And of course, you've still got the same things that are helpful for Epstein-Barr, if you like, more systemically. The same things can help in the gut as well. But in my experience, we never see that. Like I say, I think I've seen that. I've seen one positive cytomegalovirus over these years, and I think I've seen one Epstein-Barr in the gut. It's not common.
Super. So then no other questions have really come up, but I can just talk a little bit about the Cowden, maybe just to, so you have an idea of what it is. It's you can buy the products separately. That's included in the Cowden protocol, but you can also get it as month 1, month 2, month 3. I think it goes up to month 9, and because it's based on that you like titrate up. So you start with some antimicrobial ingredients, and then it's in tinctures. So you take 1 drop, and then 2 drops the next day, and 3 drops the next day, and you go up, and then you continue with 1 protocol for about a month, but then you may continue with something and then change something to another antimicrobial or antiviral that comes in. And I remember, I think Hutunia is in months 3 or 4. That's when I especially started reacting, because I had Bartonella, and that's very specific for Bartonella. So you can actually, the patients can feel when a new product comes in, if they're responding, of course, they can feel when a new product comes in, and you have to titrate up slowly because of Herx reactions and so on. But it's quite a neat protocol. It's quite expensive, but it's and it's like you have to drink these tinctures 4 times a day so that you're in constant, but there's ways around it. And I would say I wouldn't do Cowden just by itself. I would also add some of the transfer factors and nutrients and vitamin D and like Artemisia I would always use on the side as well, but really be aware of drug interactions, but not just drug interactions. Also, I have had 2 patients where they have turned like yellow, and it has had impact on on their liver count. So I'm always I tell my patients, start slowly, even though I don't know about drug interactions. I always say start slowly, and especially when we're dealing with some of the herbs, because you never know how it reacts. I mean, I've even had a patient going to hospital because she's been taking ashwagandha, which is not really known, not even in the natural medicine database. Well, maybe it is now, but it wasn't when I was using it. And then suddenly 1 study had been published with 4 cases of patients who had like liver impact. So always just get the patients to start slowly, ask them to stop if they feel too bad. And then even just Herxheimer's reactions can of course cause increased liver count. So then, I think that's kind of enough about Cowden. Klebsiella and how to treat it. Klebsiella pneumoniae. I would. So it's what is it, the drug for that? Graeme, help me out here. I'm a little bit rusty in the drugs for.
Well, actually, I don't know, but I mean, with Klebsiella, we usually
azithromycin. Sorry for interrupting. Okay, azithromycin would be the one that you use as a drug for Klebsiella. But otherwise, sorry, I have had lots of effect also with, and there is a product called Oigaresp with oregano and thyme and cinnamon in it. So that's my go-to products, but really Klebsiella. Sorry, I'm talking about chlamydia. Sorry, I'm even messing it up here. So, no, chlamydia is what I've just been talking about. Klebsiella, I find more in a stool test.
Yeah, so use, I would definitely use a biofilm disruptor with Klebsiella. And then we tend to use broad spectrum herbal treatment. So for example, like Biocidin, broad spectrum, or berberine and grapefruit seed, Nutri product, or we would is it GI synergy? Is that another broad spectrum? So I think Klebsiella is, there's not necessarily one perfect way of treating that antimicrobially. So we normally go interphase plus and some kind of broad spectrum herbal treatment for the gut.
Super. I'm just was just asked if I could write it down, but then that was for chlamydia pneumoniae. Azithromycin it was, but that didn't help on Klebsiella. So are there any other questions are really coming up from what I see here? But I think in general, I mean, we as practitioners, and now I'm opening up for a broader thing, like we have to evaluate, like, is it mold that we discussed last time? Because mold can make the lymph group go high and or swell up and impact immune response. So you may think it's an infection, but it's mold. And then there's infections, but you can have mold and infections at the same time. I was actually at, it was an ILAS conference I was in Boston, where Richie Shoemaker discussed the mold issues and mold toxicity at a Lyme's conference. So one thing doesn't go without the other necessarily. So is this like, how do we evaluate if the patient has these infections, or is it something else? And I think very much it's a gut feeling. It's listening to the patient's story. What's their infection story? What's their environmental story? And then move through that and try and understand the patient. And of course, use testing when possible and appropriate, because some of the prices are quite high. And someone is actually asking what the prices are. And I think if you go into VMS, because it depends on which test you're using and which infection, and if you want to do antibodies and Elisbot. So it's like a whole puzzle that you have to put together. But the TICPLEX that Graeme showed in the beginning is a lot of tests in one. So you actually save some money if you want to put them all in one. Another question came up about transfer factors. You can get them in VMS. It's they are called, it's a yellow product, yellow brand. What are they called? Who has transfer factors? That's not Physicians Advanced. I think you just mentioned it.
Research Nutritionals.
Research Nutritionals, yeah. Exactly, yeah. Thank you for voicing you got down there.
Yeah, I mean, a lot of the infection, if you like, products are from Research Nutritionals. Actually, they at least provide a lot of the foundation for treatment, if we're going the complementary way rather than antibiotics. So, but the downside is a lot of their products are quite expensive.
Yeah, I'm just gonna show it.
But they are really great. They are really great products.
So we have them. You can in VMS you can go in and choose manufacturer, and you can choose Research Nutritional, and then the different products comes up: messenger, multi-messenger, and transfer factor. L plus is the one that Graeme just mentioned. Then they also have different Artemisia products and other products, but they're in the system. And also, I'm just going to search in a different way. And do them up here. And otherwise, for all the rest, you just have to bank. But here you see month 1, month 2, and there's quite a lot of ingredients in each, and the price is not cheap because this is every month. So when month 1 is over, month 2 is the next one. So there you go. But you can also look for more specific ingredients in the protocol. But the company, if you want to look at those, are called Nutritionals. And then you can find the bottles. So you should be able to find bottles single as well. No, I can't. Oh, it's because I still have the carton here. So Nutritionals search. But that's a way of searching in the system that you both can choose just the manufacturer, and then you get everything that's under that manufacturer. So it opens up for more specifically. So like if I have a patient where I'm only treating virus, I wouldn't do a whole carton. Carton is like Lyme's and co-infection, or the whole month 1, month 2 is carton and co-infections. But if I have just a virus that I'm treating, I would go for more like a viral protocol as inspiration. So, let me stop sharing again. So did something else come up? Yeah, Clear Labs and Research Nutritionals. Yeah. So, but again, if you want to work with biofilm, then that's maybe another product you want to use. So it is a bit of a puzzle. So we're going to share the Graeme slides and use them as a protocol inspirator and see if there's areas that you can work with when you work with your patients. So, yeah. Anything else? Do you want to add anything, Graeme, or is it nearly 5 o'clock?
I mean, I just think it's so it is difficult because if it's not clear that it is infection, but there's some indications of infection, and especially like treating. So I have a lot of experience working with, especially herpes family viral reactivation. And patients may need to be on a protocol for a number of months, and they may need to go in and out of pharmaceutical treatment, like acyclovir, for example, with the complementary supplements as well. And it can be tricky at times because it does take time. You're going to have to be consistent and persistent, and you may have to layer in a lot of additional supplements as well to actually get the result. So I think unless you have a very good result just from pharmaceutical intervention directly, often patients are on these protocols for at least a number of months, and it can be difficult to motivate them through it if, of course, every patient wants a quick fix. But if you've got I think that the thing is, if you've got very clear symptoms with at least a strong result via one of the methods of testing, like Elisbot, for example, which is the one I use mostly for viral reactivation, then you can, it's easy to understand as a clinician that you're going to have to advise the patient that this is not going to be a 1 to 2 month protocol. Most likely it's going to be a number of months, and then we can retest the Elisbot in like month 3 or month 4 and see how the numbers are doing, and then obviously draw them off the protocol if their symptoms are better or the Elisbot is getting to a negative result. I think that's many years ago I got into Elisbot and viral reactivation, but I think through a lack of experience, I wasn't pushing the patients enough. I was doing like a 2 month protocol, and it's expensive, and then they were questioning the protocol. So you're feeling as a practitioner, well, if you're not getting results in like 6 weeks, then pull them off it because it's such an expensive thing to do. But then with time and more experience and just daring to go a bit longer, that's where really we saw better results in those cases, and actual like reversal of symptoms. So I think sometimes you need to be brave, and it is expensive. and need to be persistent. But I think it helps to be very sure that that's if it's a borderline positive and we get a few Borrelias like that, then usually we don't necessarily treat that there and then. We'll go and rule other factors out first before we will come back around to a Borrelia treatment, for example. But it's not easy, and it's a bit of clinical work and, if you like, intuition along with the data from the tests, and working as a team. If you can work with a doctor as well, then it's much more helpful.
Someone asked about alcohol in the carton. Yes, there is ethanol in it. There's just one product here that contains, so that's the only way of being able to preserve it currently. But so that needs to be kept in. But I actually kept mine in bottles, kind of with water, and so it got aired off a little bit. But people give it to children as well, and just give it at half dosage. So. Someone is writing, I use monolaurin, lysine, vitamin D, and gut support program. Is there more that can be done, in particular for ocular herpes if you dip regularly?
There's antiviral eye drops. So you may need to use both, or get an antiviral eye drop prescription, as well as using the other factors that you've mentioned here.
Yeah, I also personally I use, but that's not so much for virus, but like if I can sense, oh, now it's dipping, just to use that expression, then I also go on a protocol. It could just be month 1, or it could just be Artemisia, or so it's a question of like how often do you dip, and when do you dip, and why do you dip? Do you dip because you've had a lot of stressful events, or do you dip because it's winter time and normally it happens in October month or something? Then if you can see a pattern, then you can start preventing it. But of course that's more like practitioners. Our patients, they don't always end up being as knowledgeable as we do, but at least our group, we get to know ourselves that well, so we can hopefully start to prevent. And then it's a question of like just taking it for a month and then off again, hopefully. But it's a question of finding that specific time to start before it tips over and you dip too much. So in regards to herpes reactivation, how often might you have to deal with the reactivation? And of course, first you need to deal with the reactivation and get them to a stage where they function and hopefully thrive. But then it's a question of what they do, how they live. If they go out and suddenly decide to run a marathon, that will probably maybe reactivate it again, and then you've kind of like wasted the time. But hopefully you can start working with them so that they begin to read their own patterns. It's just my thoughts. Graeme, do you have any additional?
Yeah, I mean, I think, like you say, there's normally got to be some, a lack of recovery related to basically expenditure, I would say, and something's got to trigger that, whether it's poor sleep or too much stress or too much work and not enough downtime, or too much exercise and not enough recovery, or of course another infection. So COVID is a good example that COVID can trigger herpes reactivation, and that's one of the theories behind long COVID, is that there is herpes family reactivation that's then not being treated. So there's a lot of different factors. It could be nutritional deficiency, and of course usually these things go together. People have some kind of traumatic or stressful event, or they're working too much, they don't eat as well, they don't sleep as well, the nutritional status is not as good, which, as we saw in that one of the first slides, everything's linked together with how, you know, the Th1, the Th2 response, inflammation, brain inflammation, etc. They're all feeding into each other. Should liver function tests be, and Catherine's just answered that in chat.
Yes, I will refer back to own GP if you are not in a clinic with a GP and you're not a GP yourself, then but very often the patients have been at their own doctor and like had like basic chemistry test done, including a liver test. So very often when then they present that test anyway. But if you don't have it, then I would say a collaboration with own GP is for sure recommended, and sending the patient back to have general lab work done, and like health evaluation by a GP, I think is always the best thing to do. I'm not allowed to practice without doing that. So it's a standard phrase I have in my journal notes that I refer back to own GP. If I then don't do it, I can delete it, but so I never forget that. But in this case, I definitely would do that. So I think that's it. So we have on the 25th of November, we have scheduled in NutriVal and Metabolomics talk. And again in December, 9th of December, it's cardiometabolic panels. And then we will have a break with some of these monthly webinars with Graeme, and because Graeme is focusing more on some of these mastering and also other what is the other one called? It's called, I have it here, mentorship programs and master programs. But we won't stop these free webinars. We will continue with them. I already have some planned on more specifically on nucleotides. I have some other things on other gut support programs, supplements that we are planning in. So I'm working on 2022 now, or at least the spring, and we will of course send invites out for that as well. So, but put the dates in for November and December for sure, and then new dates will come for 2022. So recordings will be sent out, and as normally, and Graeme shares the slides in the mail as well. So thank you, Graeme, again for a sterling presentation.
Thank you.
And take care, everyone, and see you soon, either on mail, call, or next webinar. Bye.